Today, my talk is on approach to amblyopia case and management with BYNOCS. As Dr. David has already explained what BYNOCS is, I'm just going to go through it, but just talking about it. It's a clinically defined reduction of visual acuity in one or both eyes that cannot be attributed to any ocular or visual system abnormality. And the interocular difference of should be 2 lines or more in visual acuity, or visual acuity should be worse than or equal to 20/30 with best optical correction. Now, this is the definition what we know, and this is basically just the tip of the iceberg. With recent advancements, we know it is amblyopia should only not be associated with reduction in visual acuity. The other aspects which also are deficit are binocular single vision, stereopsis, and contrast sensitivity, which we always forget in our clinical assessment. So in your clinical assessment, whenever you have an amblyopic patient, we do our basic testing where we do a history taking, we ask for chief complaints, we ask for any past ocular history, whether the patient has changed glasses, has done patching before, or have done any surgeries. Along with that, we do an objective and subjective refraction. But it is also very important to do a cycloplegic refraction for your amblyopic cases. Along with that, you need to do an anterior segment and a posterior segment evaluation to rule out any abnormalities. This is your basic testing. Along with that, you need to do some monocular testing where we check visual acuity for distance and near in logMAR. With that, it is very important to check low contrast visual acuity and contrast sensitivity and fixation pattern, which can be assessed through a direct ophthalmoscope and an OCT machine. After that, a binocular assessment is important, where you need to know if the patient has fusion with the help of a Worth dot test. Also, the strength of suppression, which can be assessed with a Baglioni striated and a neural density filter test. With that, you can check near and distant stereopsis, also ocular alignment to see if there is any deviation. All these tests are important for us to know what will be the prognosis and with the treatment we give for amblyopic patient. The treatment of amblyopia, as Dr. David has already mentioned, it's patching, penalization, and dichoptic therapy. With any treatment, our goal should be not only to improve the visual acuity, but also to improve the contrast acuity, restoration of binocular single vision, and to develop stereopsis. Since we all know that the first mode of treatment we always give is a occlusion therapy, patching. But this treatment also has a few shortcomings. That is, not always complete amblyopia is treated. There'll always be 1 or 2 lines of residual amblyopia. Along with that, poor compliance, where the child does not like to wear the patch and move around. So you don't see a lot of compliance to this therapy. Also, because it's a monocular treatment, the recurrence of amblyopia is quite high. That means when you stop the treatment, the chances of recurrence, of going back to where it was before, is quite high. And also there is no improvement, not always there is an improvement in stereopsis. And it's highly ineffective in adults. So if you have a patient who is above 18 years old, you don't prescribe patching as a mode of treatment. Amblyopia is now recognized as a binocular problem. So new treatment modalities aim at treating both eyes together. One such modality is called the dichoptic therapy. And this video will explain how we use dichoptic anti-suppression therapy in BYNOCS.
Dioptic therapy, a contrast-adjusted stimulus, is presented to each eye, with the better eye getting the stimulus with reduced contrast. It promotes development of binocular vision by reducing inhibitory interaction and suppression within the ocular dominance column. BYNOCS now offers this dioptic anti-suppression therapy in the form of games. The better eye receives weak, noisy signals as compared to the amblyopic eye. With progressive improvement in visual acuity, the games can be made more difficult with control on the size, speed, and crowding of the stimuli. There are different games with a scoring system for better patient engagement and compliance.
So as explained in the video, you give them analglyphs, which can either be a red or a blue, or blue and red, or green and a red. Here we decrease the contrast of the good eye to the level of the weak eye and give them activities. Now the protocol of BYNOCS anti-suppression therapy is in the first phase is in your clinical setup, where you first give a full refractive correction to the patient. And if the patient has any amount of squint, you give them prisms, you prescribe them prisms. Now, in phase 2, where the patient is being prescribed BYNOCS dioptic therapy, we give them dioptic exercises to first eliminate the suppression, which will help in improving their visual acuity. Once the visual acuity is improved, you give them activities which help in improving and developing the stereopsis. After developing the stereopsis, we give them activities to normalize their convergence and divergence if they have any amount of deviation. In BYNOCS, we give 30 to 40 minutes of gameplay in a day, which should be 5 days, or if the patient wants to do 7 days a week is absolutely fine, but 5 days is minimum what we prescribe, and minimum of 30 sessions to an extent of 6 weeks. These are the different activities. One is a super ball, super car, Superman, super dragon. It is not only giving one activity. We give different activities so that the patient doesn't get bored doing the same activity. And then there is a super ball, there is a super balloon activity, which helps in developing the stereopsis. Now I will be going through few cases, which will help you to know what type of different cases we have been treating. So this first case is of a 23-year-old female anisometropic amblyopia. Your patient was given full refractive correction, and with that, the patient's visual acuity was 6/24 N18 and did not have binocular single vision. Post 30 BYNOCS session, patient's visual acuity from 6/24 improved to 6/7.5 N6, developed fusion for distance and near, and also developed stereopsis. The second case is of a 10-year-old female strabismic amblyopia. Here, the patient's vision was 6/12 N6 and had a squint. So prism was prescribed along with the glasses. Patient already had fusion with the glasses. However, the stereopsis was absent. Post 60 sessions, so first we gave patient activities to improve the vision, dioptic activities. Then as the patient's fusion was already improved, we gave stereo acuity improvement activities. So post 60 session, patient developed stereopsis to 200 seconds of arc. Advantage of BYNOCS dioptic therapy is the excellent compliance, because you only give 30 minutes of gameplay and you see faster improvement in visual acuity, that is 3 to 6 lines in just 6 weeks time. Restoration of binocular vision, it's highly effective in older age group, and you see no recurrence because it's a binocular therapy. So whatever improvement you get, it stays as it is. You don't require booster sessions later in life. Limitation of BYNOCS dichoptic therapy is that the patient should have a bifocal fixation and motor alignment. So if the patient requires prisms, you need to prescribe them and then start with the therapy. And for patients with eccentric fixators, the visual prognosis is going to be guarded. So I'll explain you through a case here. This case is similar to case 1, where patient was given full refractive correction and the vision was 6/36 and 36 and did not have a binocular single vision. Post 30 BYNOCS session, patient improved by a line, that is from 6/36 improved to 6/24. However, the near visual acuity from N36 improved to N8 and also developed fusion for near. Now, the reason this patient did not reach to its maximum threshold of vision is because the patient was an eccentric fixator. So now here there are 2 reports in front of you. Left report is of a case 1 and right is of case 3. Now, if you see here, the cross is not coinciding with the fovea as it is coinciding in the left eye. So that's how you know in an OCT machine that the patient is an eccentric fixator. Now, in case 1, where the patient had a left eye amblyopia, the cross is coinciding. The fixation pattern is basically a central fixation. That is why the patient could reach to its maximum threshold. Now, the take home or the conclusion for you is going to be a thorough clinical evaluation for you to understand the prognosis of the case. Also, an adult amblyopia can be treated with the help of dichoptic therapy. This is an online mode of therapy for amblyopia. So patient need not come to clinic and do the therapy. It can be done at any part of the world. And for faster outcome in your for faster outcome in vision, BYNOCS can be a better tool to be prescribed for your amblyopia therapy. Thank you.